I'm going to just quickly walk you through how a report would be generated for practitioners, focusing on each of these components related to AI-CVD, CAC, lung, valves, aorta and pulmonary sizing, liver assessment, liver fat assessment, muscle and visceral fat assessment, pericardial fat assessment, and that the chambers that we extensively discussed. So with that, I'm going to ask Dr. Agatston, we're going back to the root, to give us a perspective of what he envisioned and what he's doing for his patients, and how he put this umbrella of cardiometabolic assessment into his perspective for practitioners. And then we'll go to other practitioners on the panel to get their insight into this. Arthur?
Yeah, Mort, this is hearing all this. This is why I first got very excited when we talked at the last SCCT meeting. And what you showed, what everybody showed today, repeats all the things I've heard and know, but I'm more excited. And starting with Tony mentioned about just the march of technology, because what we talk about and do is not just coronary calcium, but we do early detection of diabetes, measuring insulin levels, and we call the Kraft test. And we're more and more interested in atrial fibrillation because there's so much you can do to prevent future episodes. And so one of the things about all this new technology of early detection is we can follow it up in so many good ways. And predicting AFib, years ago, if you predicted it, well, how are you going to know when somebody had AFib? Now we have the loop recorders, and if somebody's really high risk, that's worth putting the loop recorder on. So you have the earliest detection, and people's first, just like the first presentation of heart disease might have been sudden death, the first presentation of having had AFib may be stroke. And it's much more common than we ever thought. So by doing that early detection is really huge. If you see by heart sizes, prediction of heart failure, it's much easier than it was before to follow and see who's really on the way to that. So and the national guidelines in all these areas have been way behind the times. And because we can do so much more with prediction, all this is important. One example is it wasn't until the immunoassay where you could follow protein hormones, insulin, thyroid. And so we know now it was really first with the immunoassay and measuring insulin levels that we can detect future diabetes by measuring insulin levels that Dr. Kraft did in the 1970s, and with what we call the Kraft test, where you could actually measure insulin fasting, and as part of sort of a glucose tolerance test, where we can really know who's going to have future diabetes. And we do that in our office now, and it's added a lot to our practice. But again, this was all just the early using insulin levels to detect future diabetes. And if you do that, you can prevent diabetes. And the other thing that you're looking at is the fat in the liver, which you can see 20 years before diabetes is there. And this is one of the things you're going to be able to do with what you're showing. And so much is preventable with early detection. It's all this is particularly exciting and absolutely doable. So all these other imaging that you're showing has very important clinical clinical manifestations and is really good. And going back to the first the early calcium score is and for coronary disease is true of preventing diabetes, atrial fib, all these other important killers, and that up and down the line, it is absolutely detectable way before we ever thought it. So it's not just the AI calcium score. I'm very proud you're calling Agatston score 2, but it's we once we have this information, we absolutely know we can prevent future diabetes, future AFib, future heart failure. It's all there and very exciting.
At
So
that time, you didn't anticipate that being such a phenomenal 35 years or so later. But were you guys driven by pathology or something? I know John was the first, John Rumberger, to show that calcium that you are seeing actually is what they found in pathology. Maybe we can hear John in a second. But when you were working on that, did you anticipate this being a surrogate marker of coronary disease?
yes, and excuse me, what we realized is you could freeze the coronaries, and we worked with then Philip Samet, who used to do fluoroscopy on every patient to look for coronary calcium. And we did that regularly, and because of that, I knew about coronary calcium in the literature. So when he came to us, it was David came with the Imatron Corporation, and he said, this might be much more accurate at looking at coronary calcium. And what we did is we dragged a bunch of physicians in and threw them on the scanner. And it was David King and Warren Janowitz, who was a radiologist, nuclear medicine guy, and they developed the first protocol. And that's the protocol we still use. The coronary, and we look for coronary calcium. And
that is the legacy that was created 30 some years ago, and now we're building on it. I want to quickly ask John Rumberger, who was with you, Arthur, back then, and he was very vocal when I started. In fact, I learned most of my calcium scoring knowledge from John Rumberger presenting at our conference at Shape Symposia. So, John, why don't you give us your perspective where we were and where you see us going?
It's been a pleasure to work with all of these people over the years. It's really been incredibly gratifying. It's interesting that what you've now gone with AI is that you've taken the volume averaging of having a 3 millimeter slice and now made it into something that is closer to the real pathology, somewhere around 0.6 of a millimeter, or with photon counting, now 0.2 of a millimeter. So if we had had the foreknowledge at the time when we started to do the pathology studies to slice the heart, not at 3 millimeter slices, but at 0.6 millimeter slices, I think we would have seen many of the things that you're now showing with AI. So it's a very interesting thing. We had the 3 millimeter slices, and just as a side note, when we first introduced the electron beam to Johns Hopkins in the early 2000s, the radiologists, we asked them, of course, to read the lungs, and they started coming back with a lot of emphysema. And I said, no, 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 you guys are seeing, this is a 3 millimeter slice. You're used to looking at 6 millimeters, and now you're seeing more details in the lungs than you've ever seen before. And as a result, you're overcalling what you might consider microemphysema, when in fact that's not the case. So it's really the same kind of issue along the way. We waited a very long time for this to happen. I see that this is going to be a great benefit to us using this type of screening to be able to do look at people much younger. We can look at sub-threshold calcification that we've never been able to look at before. And with all of this, it's been 35 years and we're still struggling to get the approval of the insurance company and Medicare. And that's something that's just a travesty, basically, along the way. So I applaud your efforts. I think that this is a major benefit to all of us that are in the prevention game and in the diagnostic game. And I think it's going to expand and live on the legacy that Arthur and his colleagues have built.
Thank you. His colleagues, that's you and him and many others that really carried this weight for a long time. And now we're at the stage that I think we're at the transition into a more broad, comprehensive screening. So I want to invite the two leading radiologists in our panel, Claudia Henschke and David Yankelowitz, tell us about how we can take the same thing with AI to elongate it, which Nathan Wong just referenced the paper that he's a co-author, an official statement by American Heart Association calling for opportunistic detection, early detection of various pathologies. So with that, I'll pass it on to you. Claudia, please take us to the lung board.
Well, thank you very much for the opportunity, but this is so exciting. We've been working on this, and the AI-CVD gives us the possibility of working together with cardiologists and apparently also pathologists to look at disease. So we have always used very thin sections, and we're now using the sub-millimeter sections, the 0.6 and 0.2, but now you've given us an automatic way of calculating the score for coronary arteries. And before we had to make it very simple we developed the ordinal score, which made it very simple to calculate, but now we could really merge and work together and find all sorts of new things that we haven't discovered. And for the screening, we screen people who are asymptomatic, 50 years and older, with 20 pack years of smoking. But these are people that haven't really been explored because they have no cardiovascular disease yet. So many of the cardiovascular physicians probably don't really see them. So I applaud everybody for all the work, and I think the future is going to be most exciting.
Thank you so much. It's been an honor working with you and David and getting to see the entire lung cancer screening world through you and the efforts that you took early on, just like John Rumberger was ignored or Arthur Agatston's work. You guys started LDCT low dose screening and you were ignored until the big trial, the NLST trial, came out and they realized what you were saying was on point. And now we're moving the field towards the same thing on a broader scale that we will be discussing at the American Heart Association meeting on LDCT trial. So with that, I'm going to pass it to David, who was basically Claudia's mirror in the entire research world on lung cancer screening. David?
Well, thanks, Mort. And yeah, this is really pretty spectacular stuff in terms of where we're heading. I think we're really entering, I know, Mort, you're probably too shy to say this, but we're really entering a new world or a new era of preventive health. That's what this is really ushering in. These just single, even low dose scans are going to allow us to do just so much in terms of disease prediction. This is going to become part, we think, of general health. We have other aspects of this which we didn't touch on, but when we read these scans now, the low dose scans, we always read them visually. Some of the things you could pull out visually, the ordinal calcium score, it was relatively easy, but it was also relatively crude. We could also look at osteoporosis. We could look at other things. Very hard to look at chamber size to really quantitate. It had to be really abnormal to say something. Now all of this is quantitative, and this is where this really has to go. And the types of predictions we can make in so many areas is really becoming apparent with this work. The other piece, there's two other things I want to mention. When you think of, at least in the screening world, in lung cancer screening, we have the patients coming back year after year. These are annual screens. This gives us a chance to not only evaluate at one time point, but quite literally annually. And so there's a lot of work we're going to still be able to do to further improve what we've already shown here in terms of change over time and how we're going to start incorporating this, or even make predictions as to when people need to come back for their next scan. So I think that's a very exciting part. The other piece of this is that these are spectacular long-term predictors. Cardiology especially is moving towards long-term prediction, not just 5 years, but 20 or 25 years. And Claudia just published the 25-year follow-up of coronary calcium on lung screening, and it was remarkably predictable of future overall mortality and cardiovascular mortality specifically. And it had, probably as good or better than any single biomarker for that length of time per predictor. So these imaging findings are spectacular predictors of future events. And I think this is the kind of thing where preventive health is really heading. So we're starting to incorporate all of these kind of things into our routine evaluations. And I think the field is moving rapidly in this direction.
Thanks, David. As you said, you guys were doing it manually, very tedious job as part of your research. In some other radiologists qualitatively mention calcification of aorta or valve or emphysema, but now we hope this will make it universally standardized so everybody can use this consistently and use it for monitoring changes. Now, speaking of these findings,
it's the great equalizer. It puts everybody at the same level, and that's what makes it so powerful.
that was a great way of putting it. Now, I want to emphasize on one component of this. I credit again Bob DiTrano, Matt Budoff put a lot of efforts on this bone density. So I was at SCCT meeting last July or whatever it was, and John Osborne walked to us and he said, guys, I have an interesting case that just echoed what you guys are doing. And so that's how I got to know him. And ever since he participated in our weekly research meeting along with Arthur and David, Claudia, and others. And so I invited John is a very accomplished cardiologist, preventive cardiologist, and is doing a bunch of innovative stuff under Clear Cardio. Invited him to share with us as a practitioner, as somebody who is early adopter. Tell us about what that case that he had, and that's actually, I'm going to show you an example of a bone density measurement. Again, wherever the scan is, from chest, upper, lower, the AI finds and reports bone density. John, let me have you share with us your story.
Sure. Well, listen, it is such an honor and a pleasure to be amongst the founders of calcium scoring. And it is, again, an honor to be presenting just some where the rubber meets the road. I think the veils are beginning to fall. I've always been fascinated by all the free data that we get from using cardiac CT. And I'm just going to illustrate a nice little case here that illustrates what we can do now. So this is a 73-year-old guy, came to us for coronary CT angiography. And interestingly, he said about 6 weeks beforehand, he had this terrible pneumonia. They pulled out 4 liters of dark fluid from his right hemithorax, et cetera. Got better. And anyway, we put him in our scanner. We're doing his cardiac CT, and we found some very interesting findings external to his coronary imaging. As we were looking at his ribs, we saw he had a healing fracture of the 6th rib, and that's about 6 weeks old. So, in fact, I saw this, and then that's when he told me the story about his quote pneumonia, and where he was very sick in the hospital for a long time, and they drew out 4 liters of blood, basically dark fluid, from his right hemithorax. So I thought, this is fascinating. And as it turns out, when we asked him, he said, yeah, just before the pneumonia, he had this really bad, sharp pain in his right rib, no trauma. And then he developed this pneumonia, was admitted, and then subsequently got better. So we thought, this is very interesting. So what we did is we then applied some of the fantastic AI tools of your AI tools, and found out that the guy was severely osteoporotic. No history of this, never been found. We found out he was terribly osteoporotic, which explained an atraumatic fracture of his right rib, which interrupted his neurovascular bundle, dumped 4 liters of bloody fluid into his right hemithorax, and was called pneumonia. None of this had been put together before. And during this whole hospitalization, no one had come up with the idea that this guy actually had severe osteoporosis as the initial instigator of an entire clinical journey for this poor guy. And in addition, another thing we found using some of the AI tools that you have is we found out he had severely elevated chamber sizes, both his LV and RV. And in fact, during his time of pneumonia, quote pneumonia, he also developed atrial fibrillation. So we then applied your chamber volumetry AI technology to his case, and found out that he had both LV and RV enlargement, and also left atrium, right atrial enlargement, and severely increased LV mass. This led to an echocardiogram, which had not been done before, and we found out he had both severe TR and MR as well. And it's just fascinating. I've always been fascinated by all the, as I call it, the free data that we can extract from cardiac CT. And now with the validation, with the AI, being able to apply this to our patients in a quick, easy, fast way, and then validate it, and then also being able to create these percentiles, so we can then determine where this patient falls on a variety of percentiles, from bone density to chamber sizes. Your AI technology added to his cardiac CT information was dramatically effective to really piece together a pretty puzzling clinical pathway, and we're able to both later attend to his metabolic bone disease, and also be able to attend to his valvular heart disease, all from one single scan, coronary CT scan, and then derive all this additional free data. So there's kind of where the rubber meets the road, and I think we're going to be really caring, particularly when the rest of the portfolio of your AI is cleared by the FDA. I think it's just going to be an incredible way to diagnose so many interrelated conditions, from myosteatosis, metabolic syndrome, valvular disease, risk for AFib, diabetes, prediabetes, lung diseases, and even osteoporosis. So back to you, Mort. Thank you so much
Thank
for
you
these
so much,
fantastic
John. That
tools.
was great. This was a surprise. I didn't see this before. Thank you. I'm going to take the screen back. If you could stop your sharing, and then bring us to the one who has done the most in our team actually using this AI on this panel. That's Tom Atlas. He is, as he introduced himself, a practicing radiologist, and he oversees several imaging centers, which I envision they are early adopters and innovators, but hopefully 10 years from now, there will be thousands of those preventive imaging centers. That's, I think, functionally. So, Tom, with that, I pass it on to you to tell us about your experience and how you see it going forward.
Yeah, I think you guys hear me okay? Voice is good?
Yes.
I think the two things that seem to come up on the calcium score side when we're doing the screenings, number one would be, the patient gets the 0 score or low score, and then they have a heart attack the next week. And that happens like once a year. And so I think that one should be able to be picked up, hopefully, right, with the new Agatston 2 and the AI-CVD. And then the other big one that happens frequently are the people they have a high score, they go back to their cardiologist and go on statins, but they still want to get another scan and they want something to follow up just to see how they're doing. And so they'll come back, and then that develops a little conflict sometimes with some of the cardiologists because they're saying, why are you doing a CAC scan if he's already on statins? And we've developed sort of ad hoc systems, using various articles, and we try to, count the plaques. We use the plaque volume. We can tell them, if your score is relatively stable, but your volume's changing, it means, maybe that's a little more risk and stuff like that. But I think having all-in-one package like Agatston 2 is going to speed things up a lot. And also, I think it'll be a lot easier to convince the referring cardiologist once you have a system, that's the new guidelines. But as far as like using the actual tools, I really like the AI-CVD. The two big ones, right now that we're using are the BMD and the auto chamber. And I think the auto chamber seems unusually popular. I thought it would be popular, but I didn't think it would be accepted so quickly. And it seems like even when we add it on without talking to the cardiologist first, and we just since we have health coaches, I'm kind of lucky in that sense. If someone comes in for a screen, as they're in the waiting room, we'll meet with them and just say, look, we're doing your CAC scan. We can also give you a little more comprehensive evaluation of your heart with the auto chamber and tell you about your chamber sizes. And then we have a little thing we explain to them. So they'll oftentimes get the auto chamber and then they take it to the cardiologist. And we've had like no negative feedback. And that's been several months now. We've done quite a few of them. They seem actually pretty happy with it. And we're picking up a lot of stuff. And I think, maybe the reason that they're accepting it so much is that at least in California, the delay in getting an echocardiogram is really long right now. So if they can get the CAC score and then they come back and they've already got the chamber volumes, they seem pretty happy with that. And then if they want, they can look at the valves and do the echo and all that later on their own. So yeah, it's been really popular. BMD, same kind of thing was alluded to earlier with that Dr. Osborne's case, right, where you picked that up. But fortunately, we can process them really quick. So if they get like a lung cancer screen and I'm looking at it and I see the bones look a little osteoporotic, or if it's a male with a compression fracture, we can ask them, do they want to run the BMD before they even leave? And so we've got their approval, and then they get an osteoporosis report. And that's worked out really well.
Thanks,
I'm really
Tom.
happy.
So what you just said, like early days, like we're measuring LDL or HDL, hopefully we will have a panel, like lipid panel. This whole package would be, it's like metabolic panel that we ordered in clinic. This would be the imaging version of that and build on it. But that's the work that we will have to build. As I said, we've published now close to 10 papers on this, and more is coming out. With that approach, I want to just wrap up the discussion by Tom actually summarized it very well. He said basically we had two things with Agatston 2.0. One is we identify that once a year call that he gets of people who had CAC 0 and had events. And then the other is monitoring density change, especially high over low density. And that's what Arthur specifically asked us to look into it. So with that approach, now how do we see the future? As you all know, we have a symposium, unofficial American Heart Association's satellite symposium that we invited luminaries to discuss what we internally refer to, David, Claudia, and Tony, and some others weighed in, of a proposed study design that would evaluate these in a very large cohort and basically set the stage for the future. So I'm going to ask David to weigh in a little bit and then go around, ask Arthur and others. David?
Well, I think this kind of a trial, to a large extent, is going to be highly useful in sort of convincing, the world really about the value of all these tools. I mean, I think they'll gradually get acceptance as we're going, but a trial like this has the potential to really solidify it. Many times, innovations require something more than just, papers and whatnot. It leads to slow uptake, and guideline agencies won't fully accept it. So a trial like this, I think, is going to be something very exciting. We're really looking forward to participating in this and, working out the most efficient and comprehensive type of trial, because ultimately this is going to lead into what we think of as a comprehensive evaluation. This is going to become the future of preventive health. That's what we think. And while it may not seem like it, we're still just scratching the surface of the type of information we're going to be extracting. This is going to continue to increase. And it's already, I think, surpassed what's available. So very excited about participating in this.
Okay, great. Thank you, David. Arthur, would you like to weigh in? We're going to wrap up the discussion with your summary of the field, 35 years, and how you see it in the next decade.
Sure. As everybody else has mentioned, I'm just super excited by all this. And certainly, with this new study, there is a lot of specific data, not so much, the theories, but to give us endpoints. And one thing, when we first did in 1991 a 1-year follow-up of our original patients, every time I saw a new lesion, and this was all manual, of course, 130 Hounsfield units, that was the threshold for calcium used in radiology at the time. I could see a subthreshold lesion. So, well, why not just decrease the threshold? There was too much noise. So my two problems were, the good news is I could see definitely lesions at lower calcium thresholds, Hounsfield unit thresholds, but it introduced too much noise. And with your new application, you can look at lower density by the patients becoming their own controls, and you're getting rid of the noise. So those are two things I saw early on, but I had no way to go forward with it. And so this is all very exciting. And and it's so much less expensive. We can do new things with MRI, with all the chambers and quant and all different areas, but it's very expensive. And this is really going to be available to the general population. So with the cost, and then and with the new trial, I think that what you're seeing is literally the age of the lesion. And younger plaques are new, the more dense plaques are older and stable. And so, discovering the exact numbers that tell us really how old an individual plaque is and how many younger plaques, less dense plaques there are, then that's going to be just a huge addition. So we'll be able to, I call it the way you carbon dated, fossils. We're going to be able to date the individual lesions and know how old they are and how stable or not stable. A lot of young lesions means that they're still progressing and you haven't treated them aggressively enough. And that we do in our practice every day. And so people, for all kinds of reasons, they're still forming new plaques. And those are the ones you have to treat more aggressively. And we do. And so that's going to be just a huge addition to tailoring aggressive therapy to the ones who really need it, and the ones where everything is stable, you'll know it.
What I think is amazing about this trial, which really makes it very promising to succeed, is that you have multiple targets. So you're not just targeting people with coronary calcium, but also people with increased chamber sizes, myosteatosis, also bone density issues. So with multiple therapies, right? So it's really taken the Rubinska trial, which, is being done in the Netherlands and will hopefully report out in the next year or two. It's taken it several steps beyond that. So I'm very excited to see this move forward. And I think, as Arthur said, this is going to be done at much lower costs because you're not having to, rescan people, but you're opportunistically examining these issues in people who already have existing scans. So it's great potential you have with this trial.
Thanks, Nathan. The paper that you were part of, official statement from American Heart Association, put also a new light into this, that this is a low-hanging opportunity for early detection. I said it before, it's really striking that we do so many CCTA, for example, today, probably close to 3 million, and nobody reports chambers volume in these patients. Nobody reports any of these items because this is not just for non-contrast. It works for CCTA as well. It works for non-gated and regular long scan as well. So we should try to bring all of us together to evaluate this. So that trial is really the cornerstone, as David Yankelevich puts it, the opening of a new era of preventive health. If we develop this, this is not just going to be for cardiologists. It's not just going to be for pulmonologists or cardiometabolic. It will have lung cancer in there. It would have the entire, pretty much 70-80% of mortality. So with that conclusion, that we plan to have that, we will have another recording at the American Heart Association meeting in New Orleans. with this trial. I want to thank our panel members for their time and for their decades of tireless research and devotion that made this presentation possible. This AI, again, this work that we have done sits on the back of a tremendous amount of work that Arthur, John, David, Claudia, Nathan, and many others have done that made it possible, and all those people who did the Framingham Heart Study and the MESA study, because without those, we wouldn't be able to apply this AI 30 years back and get these wonderful results. So thank you very much for your time. We hope that this education, this is again, was to raise awareness. Some of these items, as John and Tom mentioned, are not available in their practice. Hopefully FDA will release those, and we will be able to build the evidence very convincingly for all of these. But I think we have now, with Tony's presentation, demonstrated that Agatston 2.0 is ready, and we should be able to get more information on those and expand it hopefully to patient care. So with that, thanks so much for your participation, and thanks to SCCT for giving us the opportunity to communicate with its members. Thank you.